82-year-old Margaret was supposed to spend her final weeks in quiet dignity, surrounded by family and supported by a dedicated clinical team. Instead, her last days became a frantic blur of unanswered call buttons, rotating strangers in scrubs, and delayed pain medication. The compassionate care her family was promised had been quietly replaced by a system optimized for volume, transforming her living room into a high-efficiency billing center where human comfort was a secondary concern. This jarring reality is not an isolated failure of a single local agency, but the calculated result of a massive financial shift across the healthcare sector. Over the last 2 decades, private equity firms have aggressively targeted the end-of-life industry, buying up community providers at an unprecedented rate. When Wall Street titans like Clayton, Dubilier, and Rice move into the hospice space, the fundamental objective undergoes a radical transformation. The traditional mission of easing human suffering is systematically subordinated to profit-driven metrics. The attraction for these massive investment funds lies in the predictable government-backed revenue stream of the Medicare hospice benefit. Under this federal system, the government pays agencies a flat daily rate per patient regardless of how many medical services or staff visits are actually provided on a given day. For a financial engineer, this payment structure is a veritable goldmine, presenting a clear mathematical equation where minimizing daily care directly maximizes the profit margin. On the front lines, this mathematical equation translates into impossible burdens for healthcare workers. Nurses who once spent hours sitting with grieving families are now assigned overwhelming caseloads, forced to rush from house to house with barely enough time to check vital signs. The pressure to complete more visits in less time strips away the emotional support that defines true end-of-life work, leaving exhausted staff to manage the fallout of an industrialized care model. The exploitation deepens when firms manipulate the hospice patient length of stay to optimize their billing cycles. Because the daily Medicare payout remains steady, the most lucrative patients are those who live the longest on the service while requiring the least amount of active medical intervention. This creates a perverse incentive to enroll individuals whose conditions are chronic but not necessarily immediately terminal, stretching out the revenue stream for months or even years. Consequently, the demographics of hospice care have fundamentally changed across the nation. There is a documented, aggressive push to recruit patients suffering from dementia or Alzheimer's disease rather than those with rapidly progressing cancers or acute organ failure. These patients often require minimal skilled nursing interventions but can generate steady, uninterrupted daily payments, turning vulnerable seniors into long-term annuities for corporate portfolios. Internal communications and whistleblower testimonies reveal the cold reality of these operational directives. Admissions directors are frequently given strict numerical quotas, pressured by regional managers to boost enrollment numbers regardless of a patient's actual medical prognosis. One former administrator described weekly meetings that felt more like aggressive sales pitches than clinical reviews, where the focus was entirely on census growth rather than the quality of the services being delivered. To achieve this massive scale, investment firms employ a roll-up strategy, acquiring dozens of small, community-based nonprofits and merging them into sprawling regional networks. The local branding often remains untouched, masking the new corporate ownership from the community and preserving a false sense of neighborhood trust. Behind the scenes, however, local autonomy is entirely stripped away, replaced by centralized management systems that dictate everything from medication formularies to the allotted minutes for a bereavement counseling session. The human cost of this centralization is most acutely felt in the middle of the night when a medical crisis hits. Families calling the local number for emergency pain management are routinely routed to out-of-state call centers, where operators read from standardized scripts instead of dispatching a familiar nurse. The agonizing wait for relief stretches from minutes into hours, a direct consequence of stripping away local, responsive on-call staff to reduce corporate overhead. Every eliminated staff position and reduced service feeds directly into the firm's EBITDA, or earnings before interest, taxes, depreciation, and amortization. To inflate this crucial valuation metric, newly acquired agencies frequently cut non-essential but deeply meaningful programs that patients rely on. Music therapy, specialized grief counseling for children, and extensive volunteer coordination are systematically dismantled, deemed unprofitable luxuries by executives analyzing spreadsheets thousands of miles away from the dying patients. Academic studies and government audits clearly illustrate the stark divide between these aggressively managed entities and their non-profit counterparts. Data consistently shows that private equity-owned hospices discharge patients alive at significantly higher rates, a red flag indicating that people who were not actually dying were enrolled just to harvest the daily payouts. Furthermore, these facilities employ fewer registered nurses per capita and rely more heavily on cheaper, lesser-trained aides to fulfill regulatory minimums. Despite these alarming statistics, federal oversight remains dangerously opaque and slow to react. The Centers for Medicare and Medicaid Services struggles to track the true ownership structures of these agencies, as private equity firms often hide behind layers of shell companies and complex corporate hierarchies. When a family researches a provider, they rarely see the massive investment fund pulling the strings, leaving them unable to make informed decisions about who will manage their loved one's final days. The resulting moral injury among the clinical staff is profound and devastating. Dedicated nurses and social workers enter the field to provide dignity and comfort, only to find themselves complicit in a machine that commodifies death and prioritizes shareholder returns. The psychological toll of constantly apologizing to families for delayed supplies and rushed visits leads to massive turnover, further destabilizing the continuity of care for the patients left behind. This instability is ultimately irrelevant to the underlying financial playbook, which is designed for a rapid, lucrative exit rather than long-term sustainability. After 3 to 5 years of aggressive cost-cutting and revenue maximization, the firm sells the expanded network to another buyer, often a larger private equity fund or a publicly traded healthcare conglomerate. The initial investors walk away with massive returns, completely insulated from the hollowed-out clinical infrastructure they leave in their wake. The agencies left behind are frequently saddled with the massive debt used to finance their own acquisition, a hallmark of the leveraged buyout model. To service these crippling interest payments, the new owners must enact even deeper cuts, perpetuating a vicious cycle of degradation and declining patient outcomes. The community loses a vital, compassionate resource, replaced by a financially fragile entity teetering on the edge of bankruptcy while still responsible for vulnerable lives. This relentless financial extraction represents the ultimate betrayal of the foundational hospice philosophy, a movement originally founded by volunteers in the 1970s to provide a humane, holistic alternative to sterile hospital deaths, has been quietly hijacked by the financial sector. The sacred space of a person's final transition is no longer protected from the pressures of the market. It has become the market, optimized and monetized down to the last breath. The aggressive tactics extend beyond the bedside and into the community, where marketers are deployed to senior centers and assisted living facilities. Whistleblowers have detailed how these representatives canvass for potential enrollees, sometimes offering illegal kickbacks or misleading seniors about the true nature of the services. Healthy individuals are convinced to sign away their curative care rights, unknowingly entering a system designed to profit from their perceived decline. Law enforcement and regulatory bodies are chronically outpaced by these sophisticated corporate maneuvers. While occasional high-profile settlements occur for fraud, the multi-million-dollar fines are often treated as a mere cost of doing business, easily absorbed by the massive profits generated during the holding period. The systemic loopholes that allow for aggressive patient targeting and minimal staffing ratios remain largely unclosed, inviting continued exploitation by new market entrants. Even when an agency begins to fail under the weight of its debt, the initial investors have often already secured their profits through complex financial engineering. Through dividend recapitalizations, firms take out new loans against the healthcare provider's assets to pay themselves immediate cash dividends. This legally sanctioned extraction ensures the private equity sponsors win regardless of whether the provider ultimately survives or collapses, completely severing financial risk from clinical outcomes. The implications of this unchecked financialization extend far beyond the current crisis, threatening the future of American healthcare as a whole. As the baby boomer generation enters its final years, the demand for end-of-life services will reach unprecedented levels, creating an even larger target for corporate consolidation. If the current trajectory remains unaltered, the vast majority of these citizens will spend their final days within a corporate structure that views their mortality as an asset class to be ruthlessly managed. We must remember that the final days of a human life are a one-time event, utterly incapable of being refunded, redone, or corrected after the fact. When pain medication is delayed by a corporate call center, or a terrified family is left alone because a nurse's quota was too high, the damage is permanent and irreversible. The trauma inflicted on grieving families lingers for decades, a silent epidemic born from distant financial calculations. Exposing the mechanics of this quiet takeover is the first necessary step toward demanding accountability and comprehensive regulatory reform. The commodification of death is not an inevitable evolution of healthcare, but a deliberate choice made by a largely unregulated financial sector. It is a stark reminder that when we allow the sacred duty of compassionate care to be dictated by profit-driven metrics, we sacrifice our fundamental humanity at the altar of the balance sheet.